mentioned how Asia is really an early adopter, and I'll be honest, I've obviously known about on-block resection for quite some time, never really used it in my practice. And then what really piqued my attention, my interest and attention in this area was really back in 2024. There was kind of a phase 3 study that came out of Hong Kong that looked at conventional TURBT versus on-block TURBT, and that really showed in a phase 3 setting that there was a benefit. So can you just talk to the readers and the audience here, just briefly, what are the high-level ideas of this study? I believe it was about 300 patients or so, but give us kind of what are the major findings in this scenario?
So we'll start with study design. This is the first
Yeah.
phase 3 randomized controlled study, multi-center study looking at en bloc resection versus traditional TUR. The patients were similar risk going into it, and you basically found that the patients who had en bloc resection had about a 10% lower risk of recurrence at 1 year post-op. So
Okay.
that's a pretty substantial difference.
That's sizable. Yeah.
Yeah. So like, odds ratios and the basic like 0.5 to 0.7, depending on what subgroup you're in, and most subgroups having a benefit. So this was like a real difference that was seen in subgroup analysis that persisted. And so once we got that data, I felt like, oh, there's a lot of validation for what I've been doing. Because when you first start, you really are slow at this because you're learning the technique, you're evolving. And I was like, man, I've spent so much extra time in the OR, I could just get these cases done really quickly. But that learning curve, like this data was really validating for that learning curve. Like the last case I did took 7 minutes to do a 3 centimeter tumor. Which was
Sure.
Sweet.
That's very quick. Yeah.
And there would be, even for a traditional TUR, most people would be like, that's quick. That's a adequately fast time. So, the data is just kind of validating what we've all suspected. The people who've been doing this for a long time. There's a benefit. And so I think that this is now the standard of care for a sub 3 centimeter mass, at least going to be the standard of care. It's just like now about adoption, education, and validation of these findings in larger cohorts. And I think generally the West is a little hesitant to modify practice based on singular studies. So we want to see things validated. And so I think as we get these validation studies, that'll really start to evolve our field.
I mean, I think what really made me very encouraged by that data was, again, you see a benefit in recurrence. And for those of us who are dealing with non-muscle invasive bladder cancer, that's really a nuisance disease, right? I mean, we see progression for sure, and that's definitely something super important. But recurrence is something we see all the time. And how do we really deal with it? We're just giving more intravesical therapy, and at times we got to progress to the next line in therapy. But seeing a meaningful difference in recurrence clearly was something that I thought was meaningful. And changing our technique for resection actually makes sense if we're going to be able to see those that recurrence, I think, sustained throughout the next when the next validation of clinical trials.
So here's a really big point. This was a primary presentation of masses. This is the person presenting with their first bladder tumor. That means before someone's gone in there, mucked around, seeded the entire bladder for risk of future recurrence.
Yeah.
And my inclination on this, like my gut feeling on this, is that that first TUR, if you miss that opportunity for that first TUR, and you do a traditional resection, you are risking reimplantation in multiple sites in the bladder.
Sure,
and
I see.
Why we have to do so much intravesical therapy is because this is happening, and we're trying to reduce the recurrence of the odds of those micro mets or micro seeding events,
implants or
microimplantation from recurring. And so I think it's really important that you take away from this that this is the first presentation of this mass, and this really is a unique and special opportunity. And those of us who are urologic oncologists, I think, man, the amount of times I see primary bladder cancer, its initial presentation is like 5% of my patients. I almost always see people who've been like treated outside, failed treatment. Okay, go to the academic guy.
Right.
Yeah.
That's a great point, and I think that's what's going to differentiate this trial from ones coming down the road as well. So Mike, this is a great conversation. I think you've obviously been an early adopter here. Any last words on on-block TURBT that you want to kind of leave the audience here with?
I mean, I think it's something that should be learned, and I encourage providers who feel comfortable adopting this kind of technology to try it. Try with small cases. You can use the existing equipment you have. You just essentially score around the tumor and then lift it up. I'll post a few more videos on my Twitter page of these techniques, so you can kind of watch and see how they're done. There's probably some on YouTube as well. Uh, and it's actually not that hard. It just takes time. And if you wanted to use a laser, if there's someone at your institution who does like HOLEP, for example, they're an awesome resource probably because you're
Yeah.
essentially using the laser in the similar way that they use and using your beak of your laser as like a resection device in the similar way they use. So I felt like the way that I learned how to do this was actually fundamentally based on learning how to do HOLEP during residency. And I was like, oh, I think I can apply that same principle.
Yeah.
So yeah, I would say try it, stick with the trigone and areas where perforation risk is not going to be a substantial risk to your patient,
Mhm.
and just go for it. It's good. It's probably beneficial to your patients and start with small tumors.